we are going to move to our interventional meeting. So welcome everybody to the weekly Wincars interventional meeting. I would like to invite the chairpersons for the evening, Dr. Asha Mahilmaran, Dr. Zakia Khan, Dr. Kavita Tyagi, and Dr. Tripti Dev. All four of them are icons in the field of cardiology. They need no introduction from any of us. Now, without any further ado, I would like to invite our first speaker for the evening, Dr. Priya Palimkar. Dr. Priya, could you please share your screen?
Yes.
Dr. Priya is going to speak about how I was helped. Over to you. Can you go slideshow?
Yeah, my slides are visible?
Yes, they are visible and you are audible.
Yeah. So firstly, congratulations to Jyotsna ma'am and all our Wincars editorial board members for achieving this great feat. So I think we'll just start with the topic.
Absolutely.
This case is how I was helped in optimizing the patient. So my patient is a 55-year-old male diabetic hypertensive, and he presented with an acute anterior wall MI. The echo showed septoapical hypokinesia with an ejection fraction of 35%. Now, when we did the angiogram, the LMCA was normal. LAD mid-segment had 90% followed by 100% occlusion, which was a thrombotic occlusion. LCX had an ostial 40% disease, mid 80%, distal again 70%. And RC also had proximal 70, and I think the PLV had mid 70% stenosis. So the plan was, it was a primary angioplasty. We just took him for a primary angioplasty and to LAD. So this was the angiogram. And you can see that there is slow flow in the LAD. Besides, overall also there is a bit of slow flow. So the LAD appeared. Usually in a primary angioplasty, I don't go for any imaging because we want a quick in and quick out just to establish the flow. So I did the plasty for the LAD using a 2.5 millimeter stent, and the patient stabilized, and we got him shifted out of the ICU, and he was okay. So after that, I had discussed with the relatives that he has disease in the other vessels as well. But I also thought that now if I want to do a multi-vessel plasty, I need to do an IVIS or an imaging guided plasty. And my plan was to do the left and the right, if possible, together. So we took up the patient again after 3 days, and even during the angiogram, the primary angioplasty, I could feel that when I engaged the left main with the guide, I felt a little drop in the pressures, and I had this feeling that the left main was not as was not really normal as it looked like. So first we wired both the LAD and the LCX. And this is the IVIS run from the distal LCX into the left main. You can see that there is more of a fibrofatty kind of a plaque. And the tightest portion was in the proximal LCX, where the minimal luminal area was 1.6. And the LCX ostium had a more of a fibrotic kind of lesion. Then we went ahead with the LAD evaluation. The LAD, when I saw the stented segment, you can see that the stent is quite undersized. So obviously there is a lot of plaque behind the stent, and the actual distal reference diameter was 3.5 millimeters. And the entire LAD was diseased with more of a fibrotic kind of a disease. And this disease was extending into the right up to the ostium of the left main. And you can see left main MLA was 3.96 millimeters square. So First, I wired all the vessels, and the distal LCX I pre-dilated and I did a deb over there. And then I wanted to stent from left main into the LCX. So since the left main was a little short, and I thought that I would go for a culotte technique. So this was the stent from left main to the LCX extending into the OM actually. It was 2.75 into 34. And then post dilated again with 3O NC balloon. And left main pot was done using 3.5 into 6 millimeter pot balloon. After that, the LAD was rewired through the left main LCX stent struts. The struts were opened using a 2O balloon, and then left main to LAD into the previous stent was done with a 3 into 20 millimeter DES. After that, again, I rewired through the LED stent struts into the LCX, did a pot again, and then I post-dilated both LCX and the LED ostia, and then did a kissing balloon and pot again. After that, the IVIS was redone. This is the LAD IVIS run, and now you can see that the MSAs were much better. So we got a MSA in the ostial LAD of 6.5, and left main MSA was 9.9. And this was the LCX. Again, the tightest portion, which was almost 1.6, had grown to 5.68. And the ostium was 6 plus. So this was the final result. And there was a lot of slow flow happening during the procedure. So I had started the patient on tirofiban. And because of that, I decided to defer the RCA plasty. And I thought we should stabilize and do it on another sitting later on. So in conclusion, the IVIS guidance was really helpful in this case because it showed me that the LAD was a stent which I had put during the PAMI was undersized. As we all know that during primary angioplasty, there is a lot of vasoconstriction as well. And sometimes if we don't, actually do an image guidance, we are using an undersized stent. And not only the stent, we could see that the entire, LAD and the LCX was diseased into the left main ostium, till the left main ostium. And so imaging also helps, of course, in discerning what is the morphology of the plaque. And it helped me to decide that I needed to stent right into the left main. And many a times calcification is not easily visible on the coronary angiogram. So again, when you do an IVIS, you can see whether there is any calcification better, and you can use any particular tools if required. Now we have seen that there are some trials, and ADAPT IVIS showed that after using the IVIS, the procedural approach changed 74% of the times, and there was a definite reduction in recurrent MI and and a reduction in stent thrombosis and TLR and TVR as well. And we all know that now the image guidance is now got an class 1A recommendation. So especially so for left main, true bifurcation and long lesions. And to my mind, I think when we are doing restenosis and also multiple stents in the same patient also, we must use IVIS or OCT as a guiding tool for giving better and precise results for the patient. So this is the MSA criteria. The initial Asian small person criteria was 5, 6, 7, 8. And the Excel, which is a large person criteria, showed that we need LCX ostium at 6, LAD at 7, and left main at 10. So as per, at least if not that level, but it must achieve at least 90% plus of the reference diameters. So with that, I'll conclude. Thank you.
Thank you, Dr. Priya. That was indeed a very nice case and very nicely shown, and you had a great end result. Of course, there was a little bit of slow flow. Couple of things is that uh, even angiographically, we were able to see that the LAD and the circumflex were diseased, one. But in that acute situation, when you had an LAD in that 90% stenosis and you have that huge clot burden over there, and your patient is not hemodynamically stable, what most of us is do, what you did was what most of us would have done, fixed the acute lesion at that time. So that's what, Dr. Priya, your camera has suddenly blackened up. So most of us would have done what you did at that point, open it up. And imaging, I agree, absolutely helps us. And especially in the acute situation, when you place a stent, there are two things which happen when there's a lot of thrombus burden. Because the thrombus gets trapped between the stent and the vessel wall, which many a times leads to inadequate expansion. The second is whenever you have an acute situation, high thrombus burden, most of us don't go high pressure and most of us don't post dilate because we're worried about the slow flow and the distal embolization which occurs, which is why many a times the stent remains underexpanded. What most of us do is if we are taking the patient back in for dealing with the multivessel, that is the time at which we go ahead and post-dilate. In your case, you took imaging, and imaging made all the difference. So you were able to see the left main, you were able to see the proximal LED, the circumflex, and then you were able to size everything appropriately and go ahead. I fully agree that imaging makes a difference. We'll take comments from all the chairpersons. Dr. Zakia.
Yeah, very nice case, and I think a typical diabetic patient, who comes to you with ACS has always got diffuse disease. So your patient has diffuse disease starting from ostial left main to distal LAD to distal LCA. You did fix up the acute problem and got away with it, and then nicely you came back and did the case. My only question is, when you did the LAD plasty, at that point of time, was there a left ventricularization of pressure trace at that time, or you noticed it later?
No, it was
Second
there at
plasty.
that time. It was there at
Okay.
that time also. But,
Okay.
but I didn't want to touch the left main
Okay.
because I was not sure whether they would want to do a multivessel plasty. I thought maybe CABG can also be an option.
Yeah.
So I just wanted to do only the culprit and come out. And I did give them the option for going for a CABG also, but they were not keen on that.
Right.
And in an acute MI, you convince the patient for a primary angioplasty, and if something goes wrong, no,
Yeah.
then
Yes.
you're in a big. And some of the patients can be very aggressive at times.
Right.
So I wanted to just keep it safe that way.
Yeah, so you did the culprit.
Yes.
Which most of us would have done the culprit
Absolutely.
at that time. And then you went ahead with it later.
Yeah.
It's fair enough.
Very nicely tackled. Good case.
Thank you.
Dr. Tripti? Madam, you are on mute.
Hi, good evening, everyone. Happy to come back in the intervention forum. And I'm so happy to see all these cases and being done so meticulously. And in the emergency also have seen our, women cardiologists. They are so cool and so nice to take the correct decision without panicking, without getting any, unusual kind of situations being handled so well. And so you can say academically and so scientifically and judicially. So that's why I want to give all my credit and 100 marks to Priya for handling it so well. and saving the patient life. I remember during F Sky, my case was like this only, that fellowship of the sky, where we first thought of doing only LAD, acute coronary, but not PAMI. But when we did the IVUS in the first hand, we saw there was a calcium plaque in the LAD and circumflex ostium also up to the left main. Then we changed the whole thing and did a double kiss. So that was the main education, that if we can do in acute coronary also possibly some kind of imaging which is handy in our cath lab, like IVUS or OCT. I think if we are in doubt, we should be taken care of by at least looking at the left main, because that is the most important culprit. And I have seen many of my colleagues also doing the imaging even during acute coronary also, if there is any doubt, to give the full benefit of the first-hand situation. And sometimes in the midnight, if patient collapses, then it is much more difficult to tackle at that time. So thank you very much for giving me this opportunity to see such nice case. And congratulations, Priya, so nicely done. And good education and good learning.
Thank you, ma'am.
Thank you, Dr. Tripti, for your wonderful comments. And I think the only problem is with imaging is that in an acute situation, all of us want to do a quick in and a quick out. Most of us don't want to take the imaging inside. Patient is unstable, hemodynamics are down. We definitely don't want to take the OCT, and it destabilizes the patient even more with the forceful injections. Many a times we take the IVUS in, but then most of the time it's a quick in, quick out procedure. But yes, I agree that if imaging is available and if the family agrees, it's worth it. Dr. Asha, comments from you, please.
Excellent case, Priya. Very well done. Establishing TIMI-3 flow in the acute situation and then going ahead, doing a perfect job with imaging is the right way to do. And you did a great job. And any particular reason that you chose Culotte technique? Any particular reason you're more comfortable with it, or any particular reasons in this case?
Yes, this is
one. Yeah, actually, one was that I am comfortable with Culotte. Secondly, the vessel sizes of both LAD and LCX were kind of similar size diameter, and the left main was short. So the other option, I could have done a DK crush or a mini crush also. TAP, I thought that also can be a possibility, but since the left main was so short, no, I thought I might not get a good ostium coverage. So I decided that it's better I'll go for a Culotte.
And you covered the LM ostium.
Yes, yes.
So whenever it's short, it's better to cover the ostium.
Yes,
it's
yes.
difficult to short stop, and that's a right.
Right.
So even in left main, they always say whatever the operator is most comfortable with, and whatever the operator has the most experience in doing. In your case, the one point in favor was that both the vessels were typically of similar sizes. I think you use similar size stents in both. But then in Culotte, what I always dislike is that, the 2-layer of metal over there, that long double layer of metal which we have over there, especially the left main is one area that I do not like to have it. Even though in the ABC, the majority of the procedures were Culotte, which they did. However, in the rest of the world, especially in the Asia Pacific, they don't prefer that. For me, my personal choice is usually a mini crush or a nano crush. Dr. Asha, what is your personal choice?
In an unstable patient, I would also go for a mini crush or a TAP technique, which is quick in and out.
Very quick.
If you have a stable patient, a DK crush is perfect. If you can do it perfectly, that is also a good procedure. But the patient needs to be stable enough to tackle all the steps. So
right.
A quick scenario, mini crush or TAP is better.
Yes.
I agree. Dr. Kavita, are you there? Some comments from you? I think she's not. Dr. Jyotsna, ma'am?
No, please go ahead. Excellent case.
Great. So I think all our chairpersons have given wonderful comments about the case. Dr. Priya, thank you so much for the wonderful case which you have shown. It shows your level of expertise. We'll move to our next speaker. We'll go to Dr. Sujata Viparla. Dr. Sujata, please.
Yeah, you can hear me?
Yes, madam, we can hear you. We can see the slide. Can
I
you go
think you can see my slides.
Yes, madam, we can see.
Okay.
But it
Okay.
needs to go to slideshow.
Oh yeah.
Yes.
Okay. You can't see my video because my camera webcam is not working. So you cannot see all the snide faces I might be doing, Sarita. Okay. Okay then. So let's
Please.
go ahead. I did it in the how to do format. So let me just present the case so that we get more experience in this format also. So I had a 78-year-old male with history of diabetes. He had no history of diabetes or hypertension. He presented to us with an anterior STEMI, moderate LV dysfunction, post-MI angina. His creatinine clearance was 54 ml per minute. His hemoglobin was 13.8. So this is his angiogram. As you can see that the distal left main looks a bit diseased. The LAD looks ostium and mid is critically involved. It's a trifurcation. There's a huge ramus, which is having around 80% stenosis. Then I'm showing more pictures so that you can make decisions. And the circumflex, as you can see, is small and diffusely diseased. And the good thing is there is a very good right coronary artery. So at this point of time, I would like to stop and ask, what are the strategies? Would you prefer a PCI? Would you prefer a CABG? The EF was around 35%. What would you do? A provisional stenting, an elective double stenting? How would you prepare the lesion? How would you stent the LAD?
What was the age of the patient?
78, ma'am.
And so I think 78-year-old gentleman and non-diabetic patient and with severe
Yeah.
LV dysfunction.
What is
Yeah.
the
30%, madam.
30%.
Severe LV dysfunction. I would always choose a PCI, go provisional from left main to LAD. Would like to image if possible, if it's available on the shelf, would like to image to decide the proper method of debulking. Because he's an elderly gentleman, may have calcification, may not also have, but imaging will give us the answer. And I would generally go provisional because from what I can see on the angiogram, the ostium of the circumflex and ostium of the ramus is not very significantly diseased.
I think the ramus is significantly diseased, Sarita,
Can we
with
have the run
almost
once again,
15
Sujata?
to
Just once more, can you
20
run it?
millimeter length.
The diagnostic?
Asha, you have to check your audio, make it louder.
Yes. Can you run it again?
Yeah, I'll do it again.
Just leave the angiogram playing.
Yeah, I think that's better.
That's better.
I'll go to the previous thing also. So this is the previous angio. The runs, you can see all the runs.
Is that a high diagonal, right? There's a high diagonal as well.
Yeah.
Yeah. There's a high diagonal also.
There's a high diagonal which is also stenosed, very tightly stenosed at the origin.
So Sarita said we will go ahead with provisional, leaving the circumflex. Asha, Zakia, what would you
I will
say?
definitely like to put the wires in both the ramus and the circumflex. Do a provisional LM to LAD with either an IVUS or an OCT imaging, depending on his creatinine. And the ramus ostium also seems to be diseased. Maybe consider a depth strategy for ramus and a stenting from LM to LAD with image guidance. The Diagonal, I can't see very clearly here, but probably that also needs to be wired and protected, and a depth strategy for that also could be done.
I see a lot of disparity in the sizes between the left main and the LED. Lot of disparity in the sizes.
Yes, there is a lot of disparity.
Our
the
approach is
other-
going to be left main over LED, right?
Uh,
So,
But the
lot
other thing is that the LED is underfilled because the lesion is very
Yeah.
critical.
yeah,
If we image, we'll actually get to know what is the actual vessel size.
yes, yes,
Right? And that can help us. The second thing is that all the stents that we have on the shelf are super expandable nowadays.
yes,
Even a
yes.
3O
Agree.
stent can go to 5.5. So I think even a size discrepancy of 2 millimeters is not a problem nowadays. Plus, I think the vessel is bigger than it looks because we have an outlet obstruction. In that situation, the vessel shrinks. So, any other comments from the panel? Jyotsna, madam?
I think we can take
Yeah.
a 3.5 stent probably into LAD, go nominal, and then post-dilate proximally in the LM. That should be fine. Anyhow, sizing
What
of
about
imaging will
the
also
mid
help.
and distal LAD? If you can see that there's a lot of diffuse disease in that LAD.
Is there some bridging there also?
Yeah, there is some bridging there also.
I wanted to talk about this 30% of ejection fraction. So I think the first we have to see the at least echo-wise the viability of the territories. What is
Ma'am, he has ongoing angina. He has recurrent angina.
Okay. About coming to the angiogram and the protection to the whether requires an any support has to be discussed with the patient before taking further intervention. Of course, the CABG has to be the first option. I am sure the patient refuses, and then you will go for a angioplasty. Because it is a multi-vessel disease, even though the non-diabetic with an LV dysfunction, according to the Stitch trial, it is a proved value to have the CABG the first option. Once the patient refuses, now coming to the definitive due to the PCI, if you see the angiogram wise is the distal left main, there is a bumps are the same. That is says that is an eccentric plug even in the left main itself. So even wiring of the vessels has to be the taken care when we are doing much more properly. And as everyone is saying, it has to be the provisional stenting from the left main to the LAD after the imaging. And of course, the diagonal and even OM has to be the wired.
Excellent. So, Dr. Sujata, can we see how you proceeded?
So basically, I didn't say patient didn't refuse. He's actually the father of our one of our employees who's very part of our family. So we was not very keen on the surgery because of the age. He was 50 kgs man. So the interesting things why we chose PCI over CABG was in view of his age. We felt that there was not much calcification. We felt there were not risk factors. The diabetes, that factor was not there. And we thought we can get away with provisional stenting. And the lesion preparation we thought was pretty simple because there was not significant calcification. So we went ahead, we started to wire. As you can see, as we started wiring, the LED was closing. So then we pre-dilated and then I did an OCT. But unfortunately, in this patient, I didn't get great images. So I did the OCT in spite of dilatation, and I inject contrast through the catheter also for clearance. I didn't get great pictures. So you can see, at least I thought, you can see that it's a diffusely diseased LED. And as you come proximally, you can see that it's a fibrous lesion, and the 2.5 balloon itself has created significant dissections, as you can see. And this is more of typical ACS plaque with a lot of macrophages and lipid plaque, as you can see here in this area. And as we come back into the left main, you can see that the left main is huge. It is almost 5. So there's some artifact, but we measured and then it was 5. So this were the bad pictures OCT run which I got. So then I pre-dilated with a Scoreflex. Even I dilated distally also. I dilated with a pre-dilated with a Scoreflex 310 because I didn't see. The important thing was on imaging, we did not see any calcification, which was very important factor. I used the same 3.510 in the ramus also, and I dilated the ostium. This is after dilatation with a 310 Scoreflex balloon. Then we started to stent, and we decided to stent with a 3.538. Adequately, we positioned it so that because as we post dilate with a 5, we'll see that 1 millimeter lengthening will be there. And so I just put the 1 millimeter inside. Then we post dilated. I didn't protect the diagonal, I just did only the ramus. Then we did a pot with a 5 balloon because you can see that our left main is very good. So now what would you do? Would you do anything to the distal LAD or you will not do anything?
Can you let it play?
Yeah, I'll play. Actually, these parts were dilated with a Scoreflex 3010.
So the only thing that is, it looks good. The only thing extra that you can do is maybe DEB it. Use a DCB just
So,
to deliver the drug.
your wish is my command, ma'am. So I took a Protige 3.530 DCB, and you can see that I dilated, and Protige 3.5 has got a special technology so that a part of it, as you can see, was not covered even with a 30 millimeter length. So I went down and dilated again with the same balloon. So this is the result with the Protige DB, which is around 3.530. Then I rewired through the struts. You can see that the ostium is critically narrowed. So then I used a 2.7512 to dilate it. And then I wanted to do a kissing with I took a Protige 320. Again, you can see it's not sufficient. So I dilated distally and I came back proximally. So I dilated, it's a non-compliant balloon, the Protige balloon. So I went like the normal kiss at high pressures. Then in a 3.512 in the LAD, then I did a simultaneous thing with a 320 in the ramus and post KBI, you can see still the ostium doesn't look great. I did a repot with a 5O balloon, and these are the final results. So I got very bad OCT pictures. So I did not post them, but I got good MSA in the left main and the LAD. So I did not do anything. I did not do an OCT in the ramus to say, but I accepted this result despite some haziness in this RFO caudal view. I accepted the result, and this is the final result. I felt the LAD, the result is very good with, and the left main also is looking as ma'am, Dr. Josna was telling, there were certain bumps and all, but that was just plaque, and we could manage it with a pre-dilatation with a Scoreflex balloon. So this is the thing. And so what balloon I used is drug-coated balloon I used is paclitaxel, because nowadays paclitaxel is more preferred. It acts in the G1 phase, whereas the DS acts in the G2 phase. And I used paclitaxel balloon because the data is more with a paclitaxel balloon because it causes irreversible binding, lipophilic, more positive remodeling, and prolonged tissue retention, and long-term stability. Long-term results are more better. And I use this balloon because it is, as you can see, you did two inflations. It has got a wing seal technology where the paclitaxel is in the folds of the balloon, and this balloon, it will not, there is not much loss while you are putting the balloon inside the artery, and the loss is minimal. And then once you inflate the balloon, its paclitaxel, it gets diffused easily into the arterial lumen. So, and this is what I was telling. The first inflation releases around 65% of the drug, and then 25% and 15. So, I mean, 65 is first, and then I think it is. It's approximately the rest of the 35% is released in the second and third inflations, and the drug delivery is always more than the minimum effective dose. So this is what I made use of in my patient, where the LAD, there was a slight miss, so I did two inflations in the initially, and the third inflation I did it a bit down. And in the kissing case also, what I did when I did the circumflex, I did one inflation distally, and then I came back and did the two inflations in the what do you call, in the ostium of the circumflex. So but with the recent cage 3 trial, you might ask me why I'm using DCB still, because the cage-free trial has been published in the Lancet, and it has been presented in the recent ESC 2024, where this is the first randomized trial of DES versus DCB. More than 2,000 patients, and they randomized to either DCB, which was a paclitaxel DCB, or a sirolimus DES. And the devil is in the details. I just wanted to note that around 20% did not have a proper pre-dilatation, so the DCB was not implanted. And among the group where they wanted to do a DCB, about 10% underwent rescue stenting. But this trial did not meet the non-inferiority. One thing I wanted to think was, this is de novo non-complex lesions. So they excluded left main, they excluded bifurcations, they excluded CTOs, and all their lesions, the length was not less than 28. So non-complex lesions, it did not meet the non-inferiority, though there was no difference in cardiovascular death. The target vessel revascularization, the dose was more at 2 years. This is a 2-year follow-up. You can see is more with DCB compared to the DES, though there was not significant difference in the cardiovascular death. So this entails more follow-up of these patients. But we have registry data where they are using more and more DCBs in hybrid situations, where they are using in long lesions, DCB distally, DES proximally, and as we can see, about 50% in this hyper study, where the DCB was used in the side branch, and the main branch, the stenting was done. So you can see they have done kissing balloon inflation as I have done, or a pot side branch pot. So it's a different approach. And they have found that they have published the 1-year results, which are impressive. But it is a registry data, and even recently they published the 2-year data, which says that there is no difference. And in a propensity matched approach in DCB-based PCI versus DES-based PCI, and where they have compared DES only strategy versus the hybrid strategy, they found that the DES lengths were smaller. Like me, I used only 38 millimeters, but approximately 40-50 millimeters I covered with a DCB in the LAD. So in such situations, the stent lengths become lesser, and you can see that 2-year follow-up, the results are better with DCB. So, but more trials are needed, and hybrid approaches reduce the metal burden in complex PCI. Preparation of the lesion is the key. You should note that there is no stent-like result. There will be residuals of 30%, because we are looking at long-term results, in which the positive remodeling, the results will improve over time, and learn to leave flow limiting dissections. These are the keys when we are doing.
So
Thank you,
Sujata,
Dr.
yeah, sorry, go ahead.
No, go ahead, Dr. Zakia, please go ahead.
Sujata, this was an anterior wall recent MI, right?
Yeah.
Yeah. So normally, when I'm dealing with a recent or an acute MI situation, I don't like to handle the distal LED in the same situation.
Yeah.
If you do that, you end up having a lot of, microcirculation compromise.
Yeah.
So in a case like this, I might just deal with the left main and the LED lesion come out, and
Yeah.
then maybe call him back again and deal with the distal
Yeah.
lesion and the ramus lesion. Because I think the ramus lesion also we have not dilated adequately. There is a definite residual lesion, and on top of that, we have used a drug-coated balloon. So that drug-coated balloon probably will not help that patient. And this patient will not tolerate closure of even a single small branch. His LV is down. If this ramus closes or a diagonal closes, he may not
Yeah.
tolerate it, and he'll come with bad refractory heart failure. Even at the end of procedure, the distal LED microcirculation, according to me, was not very good.
Yeah.
Yeah.
So points are well taken, but I already dilated with the Scoflex distally,
Yeah.
so I was forced to put it, and
Right.
already I dilated the ramus also, and I was thinking of almost EDS a provisional, and if nothing happens, I was planning to do a tap actually, but I went ahead with DCB. So I changed my strategy in between.
Dr. Sujata, great case. Now, see the way that you went about it, that is also one of the very nice ways to deal with it. But in an acute situation, elderly patient, severe LV dysfunction, what I would normally do is wire both and stent provisional left main to LED and wait and see what happens to the ramus oblique the high OM. Because in some views, it looks like very high OM. Many a times when you stent left main to LED, nothing happens to the ramus. Because the moment you dilate the ramus, then something or the other you have to do with it.
Yeah.
Again, distal LED also, I would have probably waited, just
Yeah.
done a provisional left main to LED and watched. If the ramus started shutting off or something happened, we can always wire it, open it through the what you did actually. Then you can go ahead and deal with it and then think about either a DCB or a two-stent strategy then. But normally in an acute situation, I like to keep the procedure very simple. The simpler we keep it, elderly patient, severe LV dysfunction, the easier it is to get the patient out of the lab. In your case, you managed to do it well. But the other thing, that your thought process behind it is very good, because see, you've ended up using only a single layer of metal, and the rest have all been DCB'd. So the idea to do a hybrid procedure, reduce the amount of metal load in the burden, and to use DCB is also a very good technique. But I think each approach has its own merits, and
Yeah.
each has its own
Sarita, see, as we go ahead in the lab, we have a plan, but we keep changing the plan. So it was tolerating, so I went ahead and did. So then finally he was not tolerating, I stopped, right? So
That's
that's,
the point. That's the
yeah,
point. Because we don't
yeah,
know at which point this
yeah, yeah,
patient
yeah.
starts, because
Yeah,
we have not taken
I
front
totally agree
NCS
with
also.
you guys. That usually I'm a very strong proponent of keep it simple strategy, and I don't know. So
Yeah, I think Sujata, you did an excellent job. And there is no doubt that everyone will say in acute, you have to be very short. But he is a known to you person. So then the thing comes is more attention versus the treatment. So you have to think about the both the things. So you
yeah,
think the patient should not come for the second time. So in this situation, even I would have been done like you only, not like a simple acute keep short and come. For other patients, we would have been done like this. I agree for your procedure. So you need not to be thinking that you are done wrongly. And that
No.
very good
I'm
is that
always thinking after the procedure.
yeah.
I should have done like
One more
this. I
thing I
should have
wanted to
done like that. I'm never happy.
Dr. Sujata, you got the patient out of the lab successfully. You did a left main to LED. You DCB'd the RABAS. You DCB'd the LED. You got the patient out. And without putting an MCS, you should be happy.
One more thing I wanted to add is about the protease. One of the another case in the US, Euro PCR itself, when they are doing the advantage of this drug-coated balloon is releasing at the 3 stages. So what they are saying is when you are using the kissing balloon also, use the same protease as a third inflation so that you don't have the loss of the drug. Previously, the major problem for the DCB is DCB should be done as whole preparation of the lesion and only DCB is the end. After that, you suppose not to do anything on the vessel because whatever drug is deposited is going to be the dislodged if you again you balloon dilated and everything. But the advantage of the protease is because it is at a stage it is released. Even for the kissing, if you use that protease balloon itself, it releases even 15% in the last one. So that is an advantage of this balloon over the other ones.
Ma'am,
Yeah, it's a DC
in
balloon.
this protease, I just for my information, it's very interesting. I need to understand, is it a must to give 3 inflations for every, I mean, can we do with just 1 inflation which gives that degree of drug? I mean, because like there are
You can-
situations when you don't want to give multiple inflations.
Yeah.
to
You
look
can
at-
deliver all the drug in that sitting, in one sitting, 1.5 minutes.
The mainly
And it's just that we need to prolong it, like the sirolimus one only then.
Yeah.
Right.
And this is a
Right.
non-compliant balloon. That's the other advantage, and that's why I used it to my advantage.
So,
I
one-
just want to ask one thing about everyone's experience in an acute MI situation.
Oh, shucks.
we are losing your
Yes,
voice.
DCB, do you feel that could DCB cause more slow flow in acute MI?
No, it's only in thrombus situations we do not use DCB because the delivery of the drug is a problem into the vessel.
So we don't. So acute
Slow flow is
situations are
like
usually thrombus. And we usually do not like to use DCB in that situation because the drug will not deliver.
Right.
Because of the
Right.
thrombus.
And also because of the prolonged inflation, no, you're stopping the flow for a longer time. So I have had a few cases where after that, the patients became little hemodynamically unstable. So I'm a little worried about that.
You can do it staged, no? With you can deflate, then go back again, and then deflate and go back.
Yeah.
Just like
Dr. Sujata, excellent result in the end. Your LAD was great. I think that will definitely sail through the patient. My own one doubt is when you do multiple inflations with the DCB, do you follow the same 60-second or do you go for shorter inflations for the subsequent inflation?
this recommendation is 30 seconds per inflation for this balloon, for Protige. So each balloon has its own manufacturer instructions and we have to follow them.
Sure. And
What
every
is the
inflation should be
duration of
30
drug
seconds.
delivery?
The duration of the drug delivery.
How long does this drug deliver?
They say, I have a slide for that. They said for, I'll just go.
Sujata, great case. And in fact, I learned a lot. Recently, I used Protage for the instant restenosis. And that was pretty long from ostial to the distal. And then distally, there was a new lesion and we had to put another DES for that. But the Protage, when I went through the literature, they said that first we need to open the vessel fully and completely and come to the complete opening of the means without any further damage to the vessel. The vessel should be well prepared, totally, completely, and the protease should be taken to the maximum time up to 80 seconds to the maximum drug delivery. at one point when it is a long lesion and the long instant, and we have to complete full drug delivery in 80 seconds. So that is what we need to see in this kind of situations. Of course, that was instant restenosis. That was a different issue, but I thought maybe I can share this, and we got a good result with that.
No,
And
for
anyway,
any
Lata
drug
got a
balloon
very good result with pre-dilatation.
preparation is actually very important in any
Yeah.
DCB.
Yeah.
Basically, we always, if we are going to DCB a vessel, we normally always like to prepare it with a cutting or a scoring balloon so that you can create the cuts in which you can deliver. However, many people also do it without that also, but generally we like to go in with the cutting.
Yeah.
Also, with the cutting, there's less flake shift, and it's a controlled cutting versus a high pressure dilatation in which you can't control it. So normally that is the rule in that. But you said 80 seconds, Dr. Sujata. Any take on that?
30 seconds each inflation. That's what they said. They told me. And your question, 10 to 14 days is how much time it remains in the wall. Okay.
Okay, so 10 to 14 days. Because now we have DCBs which are coming in with an extra long duration of elution. So now you have a 90-day eluting DCB.
Yeah.
And that's amazing.
Yeah. That's really amazing.
Yeah.
So I
did the first case today.
It's a very, very difficult to do a clinical trial. See, like this trial, they've chosen non-complex cases, no left main, nothing. So it becomes very difficult. Even we don't use in such de novo lesions, which they have said, we usually do stents. Like whatever the recurrent cage-free trial, all those trials. And also, I forgot to mention, they compared the small vessel less than 3 versus more than 3. And they found that the results were better in the less than 3 with DCB. I mean, DCB was equivalent
Actually
to that
superior.
of stent. Yeah.
I think basically the indication still remains that it's small vessel, diffuse distal disease, or bifurcation vessel, and instant restenosis. So I
And
think
I'm using a lot of hybrid strategies like this. I'm using in the side branch in bifurcations. I've stopped using stents, decay crush, and all that, except in the left main situation. Except in the left main situation, when there are dominant circumflex, of course, I would go ahead. But otherwise, I'm trying to reduce the metal burden, especially in older individuals.
So, Chata, I'm really congratulate you for such a complicated case handled so well. I was just thinking about the support to the patient, whether how much pharmacological support was needed on table, or any IABP support.
No, I did not use
beforehand.
any IABP support, but maybe from what I have started doing is I've started measuring the left ventricular and diastolic pressure before doing the procedure. I mean, recently I started that measuring the LVEDP, and if I feel that there is severe LV dysfunction, it is better, I think, to measure the PA pressures also, and then take a call on the, many people are not like Sarita, they can't go ahead and do the impella, so I have to use the poor man's the strategies before. So though I did not use any other additional support in this patient.
Dr. Sujata, you did
anything.
But
you did a great job, and I was sure that at some point during our meeting you were going to pull my leg. So on these wonderful notes, we've had 2 beautiful presentations. We've exceeded our time limit, and great cases by Dr. Sujata, Dr. Priya, great comments by our expert panel, Dr. Asha, Dr. Zakia, and Dr. Jyotsna madam, and Dr. Kavita was not able to make it. And thank you so much, everybody. It's been a great meeting, and good night, everybody. Thank you so much.